Hi.
Hi.
How are you? How's everybody?
Good.
Jean's good. How's everybody else?
Good.
So we are at hump day of week 7. We're inching closer. Hi, Bernice.
Hi.
You're not driving, right? You're listening?
Yeah, I'm not driving.
Okay, cool. Anybody have any good stories? Okay, Hunter, I'm just looking at your ceiling. You could just come into, there you are. Cool. Okay, just trying to get everybody in here.
I had a question about the peer review assignment and just the
Yep.
assignments in general this week.
Uh-huh.
So we're supposed to post our group assignment the same as we did before, like as a document link, and then reply to those.
Yep.
And then the
Just-
peer review pages, we use your template, fill it in, and then send it just to you.
Yes. Yes. You can send it to me. Yeah, you can send it to my email. Sure. That'd be great. I thought we had figured out a way to upload it into the module, but I don't think that happened this term. So that's a good question. So yeah, you can send the peer reviews to me. And remember, the peer reviews are part of the rubric. They're that last section on the rubric. So don't forget to submit the peer review. Okay.
Right,
And you don't need one per teammate. You can just do one peer review for your whole team.
Sweet.
Does that answer your question, Ashton?
Yes, ma'am.
Okay. If everybody could put their name and their campus in the chat, that would be great. Let's start out with that. Okay. Okay, Maria. Oh, Ernesto. Okay. All right. All right. All right. I was confused. Okay. Okay. Julie, I can't see you. It's dark. I still can't see you. I'm looking at the ceiling. Julie. I need to have everybody on camera, please. Julie, are you there? Oh, there you are. Okay. All right. Hey, Kara.
Hello.
Hey, I'm looking at your ceiling. Can you pull the camera down a little bit?
Yeah.
Thanks. Thank you. Thank you. Okay, let's get started. So welcome to week 7. I'm going to cover the 2 chapters from last week while you were taking your exam. Congratulations to everybody that passed the exam. Had pretty decent scores on this exam as well. So really good job. Didn't have a lot of attendance at the live reviews, but I'm assuming that you watched recordings. Is that a fair assumption? Okay. Were the live reviews and or recordings helpful?
Yes.
Okay. I will check on study guide 3 for exam 3, since that will be coming up in a couple of weeks. So hopefully we'll have that out for you this week. Okay. I'll check on that. Everybody should have received the HESI study guide this week. Okay. Probably something to not wait till the week of HESI to look at. It can be pretty overwhelming since it's such a long document, but essentially what it is 10 weeks worth of content all summarized into a HESI study guide. And that HESI study guide, after we look at previous HESI exams and see what topics were asked, what concepts were covered, that's how we do the HESI study guide. So it is specific to HESI. We don't know the questions, but we do know the topics that it covers and the concepts it talks about. Okay, so I would highly suggest you start looking through that in the next couple of weeks, just so that you're not overwhelmed. I mean, I just don't want to overwhelm you going into week 10. Now, remember, we're in week 7 now, so we'll cover 6 and 7 content today. Next week will be week 8. So next week, and I think we have like 8 chapters next week. Next week will be the last week of content for you guys, right? So by the end of next week, everything on the study guide should be covered, and really everything in the HESI prep, at least the topics are in there that are going to be covered. Okay, and then week 9, you have an exam 3, and then we use week 10, our class time, to do a HESI review. Okay, so that's our week 10 class time. The other thing about week 10 is I think we have 12 or 13 sections for community. As long as you attend this one, which is your home lecture time, you are, and we'll send out the schedule, you are more than willing, you can go to any of the other professors' classes that week in week 10. Okay. Because we'll all be covering the HESI study guide. And everybody should be providing the same information from the study guide. It's just different ways of presenting. So week 10, you'll have lots of opportunities to go to lots of different reviews if you want to. Everybody will be doing week 10. Week 10 will be HESI review. And then week 11 is your HESI. And then week 12, the end of week 11, depending on when you take it, early week 12 will be your remediation. Okay, so tonight you have your group project due, at least the initial one. And I realize that everybody will be, all the groups will be submitting the same document. I understand that. And then you'll have until Sunday to do your peer reviews. Okay. And then I hope everybody has started to work on their vulnerable populations project. That is due in 2 weeks, 2.5 weeks. I don't believe it's due Sunday of that week, but hopefully everybody's working on that. That's all I can think of for right now off the top of my head. Does anybody have any questions? Okay, Jessica. Hi, Jessica. Is Jessica there? Hey, Jessica. How are you?
I'm good. How are you?
Good, good, good. Thank you. Anybody have any questions about that time frame? Okay, let's, what I'd like to do is cover content for this last 2 chapters last week and for this week. And then I would like to do a week 7 Kahoots for these 4 chapters from this week. Okay, that is what I would like to do. Okay, all right. Let me share my screen. Just want to go into the, let's see, into the module. The other thing too about exam 2 is if anybody wants to review it, I highly encourage the students who got below a 78 to schedule some time with me. Anybody above a 78, I'm also willing to go through the exam with as well. So please, please schedule some time with me. Okay, we are in week 7. So this week we have your group discussion and your peer, and that's it. Okay, so we'll do the attestation at the end of class. How's that? Okay, so let's start with the 2 chapters from last week. Okay, community assessment and evaluation and health education in the community. I think I'm going to do chapter 14 first, health education in the community. Okay, tell me what you think about health education in the community. What does it entail? Why is it important? Tell me what you think. I know in your current jobs that you probably do a lot of education, right? In the hospital setting, the long-term care setting. What do you think education in the community looks like? Okay, who can I not see? Jessica, I still can't see Jessica. Everybody make sure your name and make sure your name and campus is in the chat. All right, so tell me, what do you think about education in the community? I'd like to hear from people. What do you think it's about?
People use Google too much.
Say
to
that again,
Google
Barb.
People use Google to Google all their information instead of, I think they get a lot of wrong information from just looking it up online.
Yep. What else do you guys think health education in the community looks like? You think it's primary interventions, secondary interventions, tertiary interventions? What do you think?
I think it's a little bit of all of them. Primary would be the best, but realistically in a community, if it's rural, like mine, a lot of it's screenings, because there's not a lot of regulation. There's not a lot of people going into clinics anyways. So a lot of it's screening and tertiary.
Okay, good point. I mean, would like it to be primary, right? But a lot of times we don't have that luxury. We're more of in a screening mode, or like Ashton said, treating chronic conditions for people in the community. Okay. So after reviewing this chapter, please have a look. Has anybody had the chance to review these readings from last week, at least from last week? Okay. So you should be able to answer these objectives at the end of the chapter. Okay. So as I go through each chapter, I've highlighted information from the chapter that helps support you answering these objective questions. Okay, so let's go through it. And remember, as I've told you every week, your outline is your PowerPoint. Okay, your PowerPoint has a little bit more detailed information, but it's essentially set up like the chapter outline. Okay, all the blue are hyperlinks right into the chapter, as are the key terms. Okay. Okay, oops, hang on. Okay, we know for a fact that one of the best ways to reduce healthcare costs, right, in the community is for people to stay healthier, right? We know that we as nurses are in the very, very positive position to encourage health promotion through education, right? Because like I just said, we're trying to educate at all three levels: primary, secondary, and tertiary. And in a community, who can be our clients? Three different kinds of clients. What are they? Our client could be an individual, right? Our client could be a family. Our client could be groups of people in the community: the elderly, the young, the mentally disabled, the homeless. Okay. One of the first things I'd like to review is Healthy People 2030 follows us through this whole book. Okay, and I'd like to review their 3 objectives for health education. Okay, remember, they outline the national needs. Okay, the national needs, they outline goals and objectives that are designed to improve health. So increase health literacy of the population. Why is that important? I'm asking. So
For them to be able to understand what to do and how to help themselves.
okay. Health illiteracy is one of the biggest problems with regards to teaching, right? So we have to be able to do an assessment of what the literacy of our population is. Okay, increase the proportion of adults offered online access to their medical record. Why is this important?
So people can have it at their fingertips.
Yeah. Anybody else?
For providers to know like what other providers are prescribing.
Yep. So if you're seeing several different doctors or specialists, everybody, like for example, I just finished up with Kaiser, but I've had Kaiser for like 10 years and had several different physicians within Kaiser. It was a very integrated system that I could go in and access any reports, results, whatever. And so could the other physicians. So good. And then increase the proportion of work sites that offer an employee health promotion program. Why is that important as a national goal?
It gives the
Because
work incentive to get screened and go get their health checked. It normally has benefits.
Okay. Go ahead, Dawn.
you get discounts on your insurance for doing like wellness programs and preventions and all of that stuff. So the people are getting benefit by lowering insurance premiums, but still having to get the education for it.
Exactly. Anybody else want to add to what Don said? And I'll add, it increases it lowers the risk of health issues, right? In its primary prevention, which is really what we want to focus on in the community, but sometimes it's really hard to do that. And so having these proactive employee health programs, I remember in my school district, we had a whole department that was health and wellness department. They would organize walkathons and have schools compete against each other for walking steps. And so there's lots of different ways these programs look, but it can only help, right? Okay, there's 3 ways we learn, all right? And we're going to talk about them here in page 253. We have to understand these, okay? And we all learn in all these 3 ways. Okay, some may be more prevalent, but we all learn cognitively, which is the thinking. We learn affectively, which is the feeling. And we learn psychomotor, okay, which is acting, which is doing the task, testing your own blood sugar, doing your own screenings. Okay, so let's look at each one. Okay, so cognitive, what that includes is memory, it's thinking, memory, recognition, understanding, reasoning. Okay. Affective includes your attitude, changes in attitudes. Okay. So for active learning to take place, nurses consider an attempt to influence how the learner feels, how they think, what they value. Okay, so when you're teaching in the community, you have to be cognizant of these 3 domains of learning because they all intertwine. And then your psychomotor domain includes performance, right? Performing a skill. Okay, it's motor skills. Okay. So those are 3 ways that we learn. I'm probably more of a psychomotor learner. I like hands-on. I can't sit in a training session that just is looking at PowerPoints, whatever. I like hands-on. How are you guys? What kind of learners are you? I mean, I know that I have to, affective domain kicks in, cognitive domain kicks in, but I'm much more of a psychomotor learner. What about you guys?
I don't know if it would be psychomotor or cognitive, but
Yeah,
I'm more of
hands-on,
a
definitely.
visual.
You're more of a hands-on? Is that what you said?
I'm not. I'm a visual.
Oh, you're a visual.
Mm-hmm.
Okay. Well, that's going to come up in that's going to come up in another part of this.
Okay.
But do you my husband, Tom, he's a thinker. He learns by thinking. His primary of the 3 is cognitive. He gets too frustrated with the psychomotor, like one of the kids teaching him how to use a clicker. He can't figure it out. What about anybody else?
I'm more of hands-on, but I do really well with like a teach back method. Like teach me something and let me explain it back to you.
Yep. Okay. Anybody
I
else?
really learned that I liked the teach back method yesterday while we were in clinical. I was in the ER and me and Ashton, we were going through and just repeatedly helping each other, getting the steps handing each other whatever was next in the process.
Mhm.
And, we were doing IVs all day. And then we had to teach back another student. And that helped tremendously.
Oh, that's great. Yeah. Perfect example. One of the things that we need to consider when we're doing teaching in the community is a needs assessment. How do you know what you're going to teach? Right? You need to know what does the community need you to do? Right? So obviously the first step is, what do they want to know? Right? And then we have to collect data about the learning needs, right? Their readiness to learn. What are the barriers to learning? Right? And then we analyze that. So we're going through the nursing process here. Right? We analyze the data that's been collected, and then we identify our three learning natures: cognitive, affective, and psychomotor learning needs. Like if you're doing an education program with a group of elderly people that have diabetes, and you're trying to help them manage it better because we know they're not using their glucometers correctly. That would be more of a psychomotor need, right? They need to have hands-on with their glucometer, learning how to use it or learning how to perfect it. Right? And then we also have to think about the client's ability and motivation to learn. Motivation is huge when it comes to teaching. If you're teaching a group that's not motivated, it can be really hard. Okay, and then you have to prioritize their learning needs. Okay. So once we identify the needs, again, we develop our goals and objectives for our educational program. The difference between goals and objectives are this: goals are long-term expected outcomes. Okay, where objectives are more short-term. So an example of a goal being long-term would be each child in 3rd grade will participate in 30 minutes of daily physical exercise 4 days a week for 2 months. That's a long-term goal. It's over 2 months. Whereas objectives, which are short-term, an example would be within 2 weeks, each child will be able to demonstrate at least 2 exercises they have learned. Does that make sense? So that's the difference between goals and objectives. And I'm sure you've heard that in your other classes, right? Let's review levels of prevention in this chapter. So this is with regards to community health education. Okay, so primary education at health fairs regarding immunizations, older adults, and people with chronic illnesses, right? So we're trying to educate about immunizations to prevent the flu, pertussis, whatever, in these populations. Okay, secondary, all right, so you try primary, you're trying to prevent something before it happens. Secondary, right? We are early screening, early intervention, early identification, early intervention. So we're at a health fair again, right? We're trying to early diagnose and treat maybe diabetes, high cholesterol, right? And we're doing screenings. We're trying to identify the groups at risk. And then tertiary is your education, say in a rehab center or an adult daycare center, right? So these, the example they give is clients who've had strokes. So the stroke has already happened. Now they're trying to help them maximize their function. So everybody have an understanding of that? Because by this point, we definitely need to have a good understanding of primary, secondary, and tertiary. Okay. Hi, Chelsea. How you doing?
Good.
Make sure you put your name and your campus in the chat. Okay.
Okay.
All right.
Thank you.
You're welcome. So what effective skills do we have to have as the educator? There's a whole bunch of them here. And I'm going to have you read these, okay? Because you need to have an understanding of what effective educator skills are. Starts with here, gaining attention, making sure you review the objectives, right? Number 3, do they have any recall about the topic you're going to teach? Do they have any previous knowledge? Okay, so I want you to go through these 7 skills of effective educators. Maybe put that on a flashcard. Okay. And I'm skipping through this because I want to get to the information that supports our objectives. What are barriers? That's what I want to talk about for a minute. What are some barriers to learning? What do you think?
Difference.
Level of understanding.
And that talks about health literacy versus health illiteracy, right? What about language barriers? What about the hearing impaired? What about the visual impaired? What about the level of comprehension? Are you teaching a bunch of preschoolers or are you teaching a bunch of elderly clients? What about their motivation to learn?
I had a quick question.
Mhm.
So when I'm thinking about this and like doing educational issues and say a community, I can understand like say like an elderly home or a preschool, something like that, because that's more just like one place.
Mhm.
But if you were to do like an entire community, say like a town meeting or whatever, and you have 4 or 5 different sets of people, you know, you have hearing impaired, visually impaired, you have a little bit of everyone. What would
Mhm.
you do in that scenario? Just have backups for everything?
Well, yeah, I mean, you would have to try and plan your education model, whatever you're going to choose to, maybe for the hearing impaired, you have pamphlets. Maybe for the visually impaired, you record it. I'm just thinking out loud here. Maybe, if there's a difference in, say there's a language barrier, maybe you have an interpreter or somebody that's doing sign language. Because
Okay, so
those are all the things you need to plan for,
right. Okay.
right? And then you have your different generations, your baby boomers, your Generation X, your elderly, your kids. I mean, there's just a whole lot of things to consider. Okay. So some educator barriers. So let's say for us, what are some educator barriers for us as teachers? Maybe we have a fear of public speaking. Maybe we don't have credible experience in what we're teaching. Right? Or credible knowledge of a specific topic. Okay. How do you deal with difficult learners? The ones that are, I don't know, disruptive or not motivated. Okay. What about if you break out into groups and people don't want to participate in group activities? Okay. What about if you're uncomfortable answering questions? For whatever reason, fear of public speaking, lack of knowledge. Okay. So as we talked about, 2 of the most important learner related barriers, this is going back to the learner, is low literacy and lack of motivation. Okay. And lack of motivation really means they're not motivated to learn enough so that it creates behavioral changes. Because really that's what you want, right? You're teaching to create behavioral changes. Okay, there's a couple of health promotion models that we need to be aware of. Okay, so health promotion, we know, helps to increase control over health. Right? It includes health education, health literacy. Okay, specifically the HBM, the health belief model. All I need you to know about this is what I've highlighted. It's a model that's used to plan programs when you think motivation might be the issue. Okay. The other two, the TTM, I'm on page 262, and the PAPM, these are usually used together. Okay. And these are behavior models that go in stages. Like, what do you think? What's pre-contemplation? What's contemplation? What's preparation, action, maintenance? Okay. So that's more for the stages of learning. Like in your pre-contemplation phase, they don't plan to change their behavior because they don't really know it's a problem or they don't want to do anything about it. Right? But then they go through the next stage of contemplation. Well, maybe I need to make a change. Well, what are the pros and cons? And then they start preparing, implementing, and making whatever change they've made. Okay. So those are the two differences. Okay. One is about motivation, health belief, the health belief model. And then one is over time. All righty. And then that's really it for this chapter. And I've highlighted this because I do want you to review this, remember this section. This is a great summary of what's in the chapter. Okay. So health education in the community is key to our role as a public health nurse or our role as a community nurse. Even if we're a hospice nurse, a school nurse, a home health nurse, education plays a very, very pivotal role in our jobs. Okay. Questions about health education in the community? Everybody with me? Next, community assessment and evaluation. Why do we need to do a community assessment? And why is evaluation so important at the end of this nursing process?
To
How do
see
you-
what
how do you-
worked or didn't work.
Yep. How do you think you do a community assessment?
You look at the population and their needs.
Mm-hmm. And remember, the nursing process is in play here. Okay, we just need to think of the nursing process in terms of community nursing. Okay, again, there's your chapter outline. We're looking at community as a client, community health, and then we're looking at partnerships, community as a partner. And then we'll finally talk about how to conduct a community assessment. Here's your objectives that we need to be able to talk about at the end. Okay, remember community-based nursing and community-oriented nursing, right? Can you guys tell me what the difference is? Remember? Oriented was a big word and based was a big word.
Community oriented is when you are orienting to the community. You are learning about it and figuring it out. And then based is when you're working within the community.
Thanks, Dawn. Excellent. You're working with the ill in the community. You're based in the community. Another term to introduce is population-focused healthcare. Population-focused is a lot like community-oriented, right? You are focused on the entire community. Okay, so the community as a whole is your client. Okay, so you're working on collective goals and objectives instead of individual health. Okay. So when we look at community, the whole community is our client. We can look at primary, secondary, and tertiary as any or all interventions when you're looking at with the community. Where if you're community based, let's say you're taking care of stroke patients in the community, really what you're providing is tertiary interventions, right? So community based is it's a lot more focused, a lot more honed in. Okay, where if you're doing community oriented or population focused, you're looking at the health needs of the whole community. Right, so that's our community as a client. Population centered practice seeks healthful changes for the whole community. So there's 3 ethical concepts that we apply, and you've heard these before, to community health. We apply our utilitarianism concept, which means doing the greatest good for the greatest number of people. Okay. We also can use our concept of distributive justice. You guys remember what that means? Distributive justice, making sure people are treated fairly, making sure everybody has access to the resources. Or we could use the concept of social justice. Okay, which means that the vulnerable groups in the population have equal distribution of resources. Okay, so those are the 3 ethical concepts, and it's highlighted. So I want you to know that. The other thing I would like for us to know is how the World Health Organization, how do they see healthy communities? Okay, what is their big picture of healthy communities? Well, they want to support individual health. They want to promote a quality of life, distributing the resources needed for basic sanitation and hygiene, and creating accessible healthcare. What is a community partnership? What's a community? Give me some examples of a community partnership. Who would the community nurse or public health nurse partner with? I'll give you an example. Let's say there's a community that has a high rate of crime. Who might the public health nurses be partnering with to tackle that?
Like the police department?
Yeah, maybe law enforcement.
Domestic abuse counselors.
Mm-hmm. Mm-hmm. What other community partnerships are there?
Can they partner with like schools or churches?
Yeah.
Clinic, local clinics.
Right. What about, we used to have a couple of big businesses locally that were in our school district that provided meals for kids after school. Okay.
Here we have it in the summertime. If kids get free lunch during the school year,
Mhm.
it was big around COVID, especially. They would send the school buses around the routes to
Yep.
deliver all these school lunches
Mhm.
and breakfasts.
Absolutely. What about food banks? What about action centers? You know, they provide clothing and toiletries and, right? So community partnerships are key in community assessment, because once you do your assessment and figure out what the needs are, you're going to be seeking help, right? Well, whether it's, you know, let's say your community has an issue with suicide in the younger population, you'd partner with mental health, social workers, maybe psychologists in schools. So community partnerships, my point is community partnerships are key in helping to solve community issues, right? The more involved they are, the more invested they are in the success. Okay. What's our role in the community? I've talked about this before. First and foremost, our role is to establish trust and credibility, right? If we're going to do an accurate community assessment, we need to be able to walk into that community and have them trust you right off the bat, right? We need to gain there. We need to express that we are credible. We do know what community nursing is. We do know what the risks of a high crime rate are, the risks of high homeless populations are. Okay, in order to be able to complete an accurate community assessment, you need to be seen as credible and trustworthy, right? So I'm going to have you read this next section on your own, because this goes through the whole nursing process, looking at community as a partner. All right, so community assessment, I'll go through the beginning of each of them, right? Community assessment is just taking stock of the community from both the inside and the outside, right? We're identifying, analyzing, whether we're doing it through a windshield survey, right? You all remember what a windshield survey is? You're essentially observing the community from your windshield. Okay. You also are collecting sources of data, whether it's through the local health department or vital statistics. Okay. Here's your windshield survey, simple observation. And here's some of the things you might look for in your windshield survey. What are the boundaries of the community? What's housing and zoning? What are the day of open spaces? Transportation, what does that look like? Stores. Are people out walking their dogs? What's the race and ethnicity of the community? These are all the things you can observe in a windshield survey. Okay. And then you do your diagnosis. Okay. So after you're done your full assessment, you can actually come up with what the needs are. Right. So you're analyzing the data and coming up with goals, objectives, what the needs are. And then you have your planning, implementation, and evaluation. Okay. Every community is going to have different needs. Okay. And then you remember this. So that's a little bit of an introduction for community assessment. Anybody have any questions about education in the community and community assessments? And again, remember, when you're out in the community, so let's say you're a community health nurse, you may be working with a specific individual, with a specific family, with a specific group in the community, or the community as a whole. Okay. And remember, in community nursing, you're working across the entire lifespan. You could be working with infants all the way up to the elderly, special needs, vulnerable populations, new families with new baby. Okay. Okay, let's move into this
I
week.
have a question.
Yes, of course.
Sorry.
Who's talking?
So
I'm going to
it's
stop.
Chelsea.
Hey, Chelsea, can you turn on your, I need you to turn on your camera. Ernesto, I need you to turn on your camera. Julie, I need you to turn on your camera.
I got kicked off.
Oh,
Did you guys have an issue? You
Yeah, I
like
did.
froze up? Okay.
Hunter, I need to try and see you. I'm looking at walls. Well, the hand's not going to do it. Sorry. I
I'm on
need
my
to be.
phone and I've got my sick daughter with me. I probably should not have showed up to class at all. Probably would have been better because my wife's asleep. So I'm trying to manage a 1-year-old.
Oh, okay. I
Wait,
didn't
what?
know that. Okay,
Sorry.
that's okay. Ernesto and Julie, can you turn your cameras on, please? Go ahead. I didn't mean to interrupt. Go ahead. Your question. Oh. Did she get kicked out too? Does anybody have any questions about the 2 chapters we just covered? Okay. All right, let's skip to this week. The first chapter, real quick, is economics of U.S. healthcare and delivery. What do we know about the economics of our current healthcare system and delivery system? What do we know? What's out there? What are you guys learning in your other classes?
We're slowly going to more like telehealth and online opportunities.
Okay, yep. What else do we know? How about the cost of our healthcare?
It's
It's expensive.
ridiculous. I heard someone in the ER say yesterday, those disposable blood pressure cuffs, the tech was like, you better hold on to that because if you lose it, we're gonna charge you $80 for it. I was like, that's freaking crazy.
We spend more in this country on healthcare than any other country in the world.
And we still don't have the best outcomes as far as the other countries either.
Yep. Here's our objectives. Okay. What are some factors that influence our healthcare spending? Well, how do we answer that? What's one of the major factors that influence national healthcare spending? I'll give you a hint. Since we have an aging population, what do we face? What is the most common, or no, what is the most expensive part of healthcare right now? It's managing chronic illnesses, right? Why are we managing chronic illnesses? Why is that the biggest expense?
People are living longer.
Absolutely. And why are they living longer?
There's more medications and stuff for everything.
Yep. Technology, medication, testing,
Not enough prevention and
right,
before the chronic illness develops.
right. And as people are living longer, we're dealing with chronic illness across the board. So number one healthcare cost is managing chronic illnesses. Okay. Relate public health and economic principles to nursing care. We'll talk about that. And then they talk about payers, private health insurance versus public health insurance. And that's where Medicare and Medicaid comes in, right? That's your public health insurance. And then you have your private health insurance. Okay. And then we'll evaluate our levels of prevention as they relate to health economics. Okay, so we know that health disparities exist. What's a disparity? Just so we're clear. Difference in something from one part of the population to the other, right? We know that health disparities, they're different among populations with regards to availability for healthcare, accessibility, quality of services, prevention, treatment. So a disparity is one group may get treated better than the other. Okay. So we know that in this country, we see health disparities routinely. Okay. We see health disparities mainly in our marginalized populations, whether it's from poor socioeconomic status, race, culture, language, sexual identity, in some cases, gender. Right? And I've said this all along, and this is so important. There is strong evidence to suggest that poverty, right, the financial stability of your family, if you're living in poverty, is absolutely directly related to poorer health outcomes. Okay, poorer health outcomes when it comes to educational opportunities or educational outcomes, poor nutrition, maybe lower productivity at work. Okay. Okay, so what are some factors that affect resource allocation in healthcare? What if you're uninsured? If you're uninsured, you're going to have less access, right? Certainly the Affordable Care Act, when it went into place in 2014, decreased the number of uninsured, and that was extremely, extremely helpful, right? But typically, we're mostly dependent on our insurance through our workers, our employers, right? When I retired from the school district last May, you have COBRA and all that you can purchase insurance through your employer for like up to 18 months. And I did that for a year before I came on full-time with Fortis and got to have insurance. But I was going through my old job, and it was for an individual, it was astronomical. Okay. So most people depend on their insurance from their employers. A lot of people can't afford self-pay or paying their own premiums.
A lot of people also can't afford their deductibles on top of their high premiums.
Mm-hmm. Yeah, and the deductibles seem to be going up and up every year. Yeah, it's really difficult, really, really, really difficult. So your uninsured is certainly a factor that affects the allocation. Your access to health services. Here's where we talk about Medicaid and Medicare. So Medicaid is intended to, it's financially based. It's trying to improve access for the poor, right? Where Medicare, the two qualifications are age and disability, right? So for Medicare, you have to be 65 or older, or have some kind of a disability, and that's at any age, right? So you can have kids on Medicare with a disability. And we hate to talk about rationing of healthcare, right? But what is rationing? It implies a reduced access to care and potentially decreases the acceptable quality that you're going to receive.
I have a quick example. So I was at clinical the other day, and one of my patients ended up having a second aneurysm in a 2-month span because he had so many meds that he couldn't access because he didn't have health care and he was of lower income, and he kept getting referred to the same like free health clinics in the area. There's like 6 in Pensacola. But the issue is they had too many patients and they had too many people trying to come in for visits that there weren't enough. So even like way back, I worked at Baptist. I did a lot of the discharge paperwork, and I would call and get people a spot at a free health clinic. Even they weren't able to get care because they were out of the hospital and they had life-threatening illnesses and they needed to be seen soon. That didn't matter. No one cared. They didn't triage who did it. More importantly, you just had to wait, and they were told there's nothing they could do about it except keep going back to the hospital, because there you have to get care immediately.
Right. How sad.
It was horrible.
Yep, yep. And that's when we talk about the uninsured, the underinsured, and the disparities that exist with regards to access, even quality. That's a perfect example, Ashton, of what we just talked about. And I think of, I mean, it's better now, but you think of the VA health system, right? A lot of the same issues with access, and, you know, just because you're a veteran doesn't get you in same day, same whatever. I mean, the wait times and the, yeah. This big issues. What are some levels of prevention for economic prevention strategies? So primary, work with legislators and insurance companies to support the ACA, Affordable Care Act, coverage for health promotion to try and risk to reduce. That's your primary. That's what we want to do, right? We want to have enough breathing room, right, that we can actually practice primary interventions. But it seems like we're just so far away from that. Everything is in the reactive, you know, rather than getting to be proactive, we're in the reactive stages, right? Which is secondary and tertiary, right? Identifying early. And so secondary, encourage clients who are pregnant to participate in the WIC program, right? Why? To increase the number of healthy babies and reduce the costs related to preterm baby and pregnancy complications. So that's early screening, early intervention, right? So we're screening them to be possibly at risk for preterm complications. So try and offer them some resources so they don't have a preterm baby. They don't have pregnancy complications that sends them into the hospital. And then tertiary. Let's say they already have the baby. Okay, so I don't know what you would call it, the event has already happened. Okay, so we have a baby at home. Okay, so tertiary, participate in home visits for new mothers who are at risk for maybe neglecting or abusing their babies, right? To try and reduce the costs of abuse and neglect. Right, so here we're educating on postpartum care, postpartum depression. We're educating on what the risks are of child abuse and neglect. Okay, make sense? And then it goes through the next part of this chapter. It just gives you a much longer reading or definition with regards to primary. So if you're having a hard time grasping primary, secondary, tertiary, I would encourage you to read the next section of this. It's on page 83. Okay, goes through primary prevention. In the middle of primary, we talk about healthy people. So let's review that. So this is all about economics of healthcare. So their objectives in Healthy People 2030 are related to access to health services. And there's a reason why Healthy People 2030 is throughout this whole book, because those are our guidelines. Those are our national standards for healthcare. All right, so that's why each chapter has its own little diagram of what the Healthy People 2030 goals are for the topic we're covering. And in this chapter, it's economics of healthcare. So increase the proportion of adults who get recommended evidence-based preventative care. Why is that important? And what is what's evidence-based healthcare? Go ahead.
Healthcare where the outcomes have pretty much been proven by evidence and previous practice. For example, one method of doing something might post greater results than something else as seen in evidence.
Mm-hmm.
So it's adopted as the common practice.
Yep. Anybody else have anything to add to that?
An example would be like how nosebleeds used to be treated. You used to pinch the top of your nose and hold your head back, but evidence-based practice suggested you're swallowing too much blood, it's making you sick, all of that stuff. So now you hold it forward and pinch the front of your nose.
The perfect example, right? So Healthy People 2020 wants to increase the number of people who get treated based on evidence-based care. It's not out there all the time. It's just not. And they want to improve the number of people who have access to, I mean, your large teaching hospitals, yes, of course. They are moving towards, I mean, everybody's always moving towards evidence-based practice, but think of your rural areas, your small hospitals. They may not have the most up-to-date information or the most up-to-date techniques or the most up-to-date research.
That
Increase-
and a lot of people in rural areas are hard-headed. I am from a rural area. I can't say that word. I'm from that area, and like my mom and my mother-in-law, they're older, stuck in their ways. Don't you tell me anything different. You know, we're gonna hold the nosebleed the old-fashioned way because that's how we were taught. And a lot of them are not open to change.
Exactly. Yep. We discussed that when we talked about the rural population. They have to have the motivation to change, and a lot of them they just don't. That's an excellent example. Increase the number of community organizations that provide prevention services. What does that increase? You can increase the number of organizations that provide prevention services. What are the benefits of that?
Increase in the number of people that it's affecting.
Yes. Well, it certainly increases the access, right? Because
Right,
if
right.
you have more organizations providing prevention services, then more people have access. And if they're providing prevention services, then maybe you can lower the risk.
Probably lower the amount of chronic illnesses in the area
Exactly.
or catching illnesses early enough.
Exactly. Yep. Increase the use of telehealth to improve access. How does that work? Why would that? How can the use of telehealth? I mean, who hasn't in the last 2.5 years through this pandemic not had a telehealth visit? You haven't? Really?
I
You've had to go in. Okay.
It's funny. I have a couple chronic illnesses already, so I have to go in regardless. And
So you
then
have
we
to-
don't get good service where I live
Mm.
anyways. So I've tried to
Mhm.
get my mom a telehealth visit because she hates going into the doctor. She has
Mhm.
reoccurrent blood clots, and she is pretty much always gonna have blood clots in her legs.
Mhm.
She hates going to the doctor because she's had a lot of bad experiences. And she tried telehealth and it would never connect, or the reception was bad, or she kept getting cut off.
So there's a barrier. That's a
For sure.
barrier. So as much as we want to use telehealth to improve our access, which actually has improved access, there are certain populations, whether they live in the rural areas, that cannot participate in telehealth, whether it's they can't figure out how to turn on the computer or they don't even have a computer, right? Or they don't have the service, the internet service. But for a lot of people, telehealth has been a huge improvement for access. I'm not sure, we even knew, I mean, we knew what telehealth meant prior to the pandemic, but it wasn't used a lot. Now it's part of our daily lives. Reduce the proportion of young people younger than 65 who are underinsured. Why is that a national goal? Because what did we just talk about? What's the downfall to being underinsured or uninsured?
An increased cost of healthcare because if everyone who is uninsured
Cost,
the ER,
yeah, cost, access, quality, wait times. Okay.
I fall into the category of the uninsured because obviously I'm not working through nursing school
Mhm.
and we lost our insurance due to cost. So I am uninsured. And a lot of people in their 20s are because of the cost. And so all of us are, we have the mindset of, well, if we die, we die. We can't afford to go to the hospital.
Mhm.
We can't afford to get our medications and stuff like that.
Well, there's always, I mean, have you looked at options like Medicaid?
See, that's where I fall into that category because we make too much for Medicaid or Medicare. Yeah, Medicaid.
Mhm.
We make too much for any type of
Mhm.
benefits or assistance, but we don't make enough to be able to cover our own insurance.
And that's how messed up our healthcare system is.
It's
know?
funny too, because where I live, it's rural out in the middle of nowhere, but a lot of people my age, which I'm 21, my best friend is 21. We have our own health issues, but we're in the weird category where I'm still living at home. My best friend lives on her own. I still pay for everything of my own, and I made too much because I had 3 jobs to where I could get insurance, but then it's still an insane amount of money that it was cheaper for me to go without insurance.
Mhm.
And the medical bills are just piling up, so it's just like a weird in between for almost everyone down here, to where you either make too much and you're getting penalized for making more money, or you just don't go without insurance, so you just don't go to the doctor and you save yourself the trouble.
Or you show up at the emergency room. I mean, you
And
can't.
just wait for it to hit your credit because you can't afford it.
I mean, the one thing that passed a couple of years ago was allowing kids to stay on their parents' insurance, at least till they're 26. And so far, I mean, I've still got one kid on my my insurance for another couple of years, but that saved them in their 20s, going to college, and it was too expensive to get the insurance at the college or the university. And so they just ended up staying on mine, but it was an arm and a leg to have them on my insurance. Just the premiums. I mean, to go from an individual to just adding one person or adding 2 people, it's like 2.5 times.
Yeah, I love
It's
that they up the age, but then again, it's the same thing. Like, I hate putting financial strain on my parents because
Yeah.
I am in a position where I can just work more. So
right,
it's almost like give or take, like put your parents through hell to pay for you, or just
right.
attempt to pay for yourself.
I made the kids pay their own premium. Like if it was 1,200 a month and mine was 700, they paid me with their whatever part-time jobs. They paid me the premium. I couldn't do it. I couldn't do it.
Well, to touch on that, so when my husband's job initially started offering insurance, I
Mhm.
went through the benefits package and that whole thing. But so the cheapest option was for himself,
Mhm.
and then the second cheapest was for himself and our kids. But if you add a spouse onto that, that's when those rates are going to skyrocket, and you're looking at $300, $400 a week.
Exactly.
And I can't do that.
Right. Yep. 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 Yeah. Tough. I mean, just tough times, tough decisions. Yeah. What are some of the demographics that are affecting healthcare? Okay. Number one, aging. Right. And here's this is fact. So if you get asked about this in an exam, remember this. The one major demographic change underway in this country is the aging of our population. Hands down. Okay. And so, as we talked about earlier today, the elderly population has created the most healthcare costs because of the chronic illness and the aging, and because they're living longer. Okay. This is interesting. The aging population is expected to affect health services more than any other demographic. Look at these demographics. Let's just do the first and last. In 1950, which I don't think any of you guys are born in 1950. In 1950, more than 50% of the US population was younger than 30. Now look at 2020. Now, younger than 30 is 17%. That's huge. So what are you going to be doing in your future nursing careers? What are the likely populations you'll be caring for? The older adults, especially if you're in the community setting, right? Technology and intensity has definitely affected healthcare, right? Innovative technology, yes, it's been helpful, but has certainly increased the costs, no doubt. Okay. And then
Did you-
financing. Oh, sorry, go ahead.
That's okay. Did you say technology has increased the costs?
Yeah. Well, I mean, look at all the new machines we have. Look at all the new, the fancy machines we have. Well, the more we use those, the higher the costs are.
Right.
Right. I recently had an MRI and it went towards my deductible, which is astronomical. I recently had an MRI. It was like $1,400. Well, I hadn't met my deductible yet. I was like, what? So technology, yes, we're quicker at diagnosing, we're fancier at putting the big picture together, but it's expensive. And then financing. How are we financing our system? And that's where I said earlier, public versus private. Okay, public support, the main two programs are your Medicare and Medicaid. Okay. All right, so right here. Okay. This is where the majority of public health spending happens with these two programs. Remember, Medicaid I always think of Medicaid. I think of the aid at the end, AID. We're trying to aid families that need financial assistance, that are below the poverty line that qualify for Medicaid. Where Medicare is your older adult or your disabled person. Okay. And then it goes through what Medicare and Medicaid are. I just really need you to know the basic differences. Remember that Medicare, which is the older and disabled, you have to have skilled nursing care. They will reimburse for skilled nursing care. What's skilled nursing care? That's if you're teaching a family how to change a dressing, or you're teaching a family how to test a blood sugar. It's not ADLs. Okay, it's skilled nursing care. And that's only covered under Medicare. Okay, where Medicaid is your non-skilled. Okay. And then it talks about private support. What's private support? Health insurance, private health insurance. Your employer's providing insurance, or you're going on what do you call them? You look on what do they call them? Portals of places. Is it right, Chelsea? Portals?
Yeah, it's the marketplace.
Marketplace. You go on the marketplace and find your own health insurance.
Yeah.
Right? And then, or you self-pay. Okay. So anyway, yeah. So really, lots of variables with the current economics of our healthcare system. Okay. Okay. Any questions about that? We're getting there. This is a tough topic. The next chapter we're going to cover is chapter 27, which is violence and human abuse. This is a tough chapter, but if you are working in the community, you will definitely be working with people who are either perpetrators or victims of violence, and certainly human abuse, whether that's partner to partner abuse, child abuse, elder abuse. Okay,
I want to be a SANE certified nurse.
so Dr. Lundy is.
Really?
Mhm.
I would love to talk to her about that.
Dr. Lundy works with the federal government, and she has an incredible job investigating human trafficking.
I love that.
Yeah, she works up in she lives up in North Dakota. And to talk with her about that particular job is fascinating.
I would
Okay.
absolutely love to do that. Now, they are rebuilding one of the main hospitals here.
Mhm.
So we're getting like this big, fancy, brand new hospital.
Mhm.
And so where I live in Pensacola is right off of Interstate 10. We get a lot of human trafficking. It's a drug run. Pensacola is bad.
Mhm.
And there is a severe lack of SANE nurses, but there's an overabundance of victims. So when they were trying to sell us on Baptist and all of that stuff during clinicals, I had mentioned I want to be a SANE nurse, and that hospital is dedicating, I think, 6 strictly SANE rooms.
Wow, that's
Strictly for that.
awesome.
Mhm. And I was like,
Well-
well, I kind of want to go over there now because of that.
Yeah, should reach out to Dr. Lundy.
I absolutely will. Thank you.
Yeah, you're welcome. We know that violence is public health issue, social issue, developmental threat. We know that there's all kinds of violence, community violence, shootings, partner violence, suicide is violence against self, right? And so there's lots of different, and violence just seems to be, I don't know, every time you turn on the news now, it's just everything's about violence. It's just so prevalent now. So Healthy People 2030, they have their 3 objectives for reducing violence. Reduce the number of young adults who report 3 or more adverse childhood experiences. You will be very involved in that if you ever get into school nursing. Okay, because that's where a lot of this happens, or a lot of it's reported and you have to deal with it in the school setting. Reduce intimate partner violence and reduce gun carrying among adolescents. So those are their 3 objectives for reducing violence. Okay, ultimately, the goal is to stop the violence before it even begins, which is assessment. Okay, so we know that societal, environmental conditions really, they really, the more stressful it is, the more challenge, the more risk it is in the environment you live in, it's going to create a haven for violence, right? Whether it's you have a high crime rate in your community, whether you live in a community that has a lot of people living in poverty, right? Whether there's a high unemployment rate. I mean, think about what happened the last couple of years with social isolation among those older kids when we were all in remote learning forever. Right? The level of violence has gone up. The level of human abuse has gone up. There is no question about that. Right? Also, rates of violence may depend on where you live. If you're living in if it's a busy community and everybody lives on top of each other, maybe age, sex, race, ethnicity, lots of factors. But violence is very prevalent in this country right now. Okay, so what are some of the kinds of violence against individuals or oneself? I just need you to know what they are. You don't need to go through and read this whole section. We have homicides. Everybody knows what a homicide is. We have assaults. Everybody knows what assaults are. We have sexual violence and rape. Okay, we all know what sexual violence and rape is. Okay. And then human trafficking. That's just a part of violence as your homicides, your assaults, your sexual violence and rape, human trafficking. Okay. And then your violence against yourself, which is still considered violence, is your suicide. And what have we seen over the last couple of years with suicide? The numbers have skyrocketed, right? Skyrocketed. Family violence and abuse. How do we as nurses, we as community nurses, well, not only community nurses, if you're working in the ER, if you're working in urgent care, if you're working in the community, how do you educate yourself on how to identify abuse? Would you be able to identify a partner on partner abuse? Would you be able to identify child abuse? Right? Do you understand what the risk factors are? You need to have an understanding of that. And it doesn't matter where you're going to work in nursing, you're going to come across this. You're going to be working with victims. You're going to be working with perpetrators. Well, maybe not so much perpetrators, but certainly victims, whether they're kids or adults or older adults. Okay. So to help abusive families, we need to have an understanding of what characterizes, an individual or a family to become involved in violence, right? Is it their upbringing, living conditions, increase in stress? Okay. What are some types of family violence? Well, I just need you to understand what the types are. Okay. Child abuse. Could you recognize child abuse? Child abuse comes in many different ways: physical abuse, sexual abuse, emotional abuse, neglect, trafficking. Okay. Would you be able to recognize which kind of violence it is? And there's a couple of really good boxes in here. Box 27.1, it's not highlighted. However, it's good reading, determining risk factors for child abuse. So I had to do this assessment over and over. It almost seemed like daily, over and over again, with kids reporting abuse in the schools. These were the questions. This was the investigation I needed to do before I report to social services. Okay. And obviously goes without saying that if child abuse is suspected, it's obviously the family is not functioning properly, right? Parents that don't have any support, if they have some underlying mental health issues, they have economic issues, or maybe they were abused themselves or at risk for abusing their kids. Then you have child neglect. So you have child abuse, you have child neglect, you have sexual abuse. Again, intimate partner. I just need you to know the types of violence. Intimate partner abuse. And what about signs of abuse? Would you be able to recognize a battered woman if she came to your facility? Let's say she doesn't have bruises or lacerations. There are other ways to recognize that, right?
Avoidance of eye contact,
Yeah.
jitteriness.
Somebody taking over the conversation for her, not able to speak for herself, right? Or there may be outright physical signs. Okay. But this is something you're not going to avoid in community nursing or really other kinds of nursing as well. And then there's the whole dynamic of elderly abuse. Right? Right? We know elder abuse is growing, right? It's growing and it's considered a form of family violence. Right? What is elder abuse? Well, the definition is an intentional or act or failure to act that causes harm or risk to an older adult. Okay. What are some signs of elder abuse? Right? Maybe rough handling that can lead to bruises or bleeding. Ignoring needs.
I worked in a podiatry office as a medical assistant, and I did a lot of geriatric patients, routine diabetic foot care, as well as a whole bunch of traumas and stuff like that. It was very versatile practice.
Mhm.
And we had several instances where we had to report elder abuse, and it was so sad. And it just makes you angry. And these elderly people can't do anything about it.
They're helpless.
Absolutely. And then a lot of the times they're just sitting there embarrassed in their own filth.
You know, when we think of violence and abuse, we tend to gravitate towards like child abuse, most common. But, you know, unless you're working with that population, the elderly population, you don't really think of it as a common issue, but it really is. And it's growing. And think about it. We just said that the number of people, the aging population is our biggest, not drain, but our biggest expense for healthcare. So as our population gets older, and our statistics just showed in 2020, there's only 17% of the population that's below 30 years old. So that's going to be an area that of great concern in the years to come. Go ahead, Ashton.
So on the flip side of elderly abuse, I know it's horrible. You know, I've a lot of side of it. I was on a med surg unit for COVID for a long time. But on the flip side, the elderly themselves are very abusive from what I've seen.
Mm.
Like more of our violent patients are elderly. And I feel like a lot of times they're not held accountable because they are old and they can't help it or things like that. And we actually had a patient who, after he was, you know, taken off of our care, he was in restraints because he was insanely violent.
Mhm.
He was on the news. He killed 2 people in his senior home because he was that violent, but no one would ever do anything because he's just old. So like the elderly abusing other elderly, I've seen as a common problem as well in like nursing homes, you know, daycares for these people while their families are at work, even in hospitals.
That's an excellent point. That's an excellent point and adds to the discussion of the elder abuse and elder on elder abuse. And I think that that is going to become much more prevalent as we have a much bigger population of elderly clients.
That's why I'm more worried about what I've
It makes-
seen. I talked to a couple like travel nurses about it, and they said especially in bigger hospitals, they're getting to where they're having a police department actually in the hospital themselves. That way you can at least write reports and have, you know, a line of documentation behind it.
Right.
To where police will take action, and that will, you know, affect what nursing homes they can get into and whether they can receive care at the hospital or not. So I think it's taking a step in the right direction, but it takes a long time.
Maybe doing some kind of a safety evaluation prior to them being discharged. If they're being discharged home to family or being discharged to rehab or long-term care, doing some kind of a safety risk, you know, between for themselves and others. And I just recall over the last, I don't know, 6-8 months, I seem to see more stories about violence in hospitals. You know, people taking weapons into hospitals. For the most recent one I read from was from a couple of months ago, where 2 labor and delivery nurses were killed because father, what was it? A couple had just had a baby or something, and maybe the mom indicated that he may not be the father, or something. And he took it out on 2 labor and delivery nurses and killed them. You know,
The
so
hospital that we did clinicals at yesterday, we had to leave early because they were doing an active shooter drill.
Yeah. Violence comes in so many different forms, and it's really kind of part of our society right now. And we just, especially as nurses, we really need to protect our own safety. And if you're in the community, I don't think we've addressed this yet, but especially with the home health nurses and out there doing visits, there's a whole area in this book that talks about safety protocols for community nurses. We have to be mindful of our safety, our personal safety. Okay. So good discussion, really good discussion. I think that was all I wanted to cover. Levels of prevention related to violence. So strengthen the individual and family by teaching parenting skills, right? That's a wonderful national goal. The better parents we can all be, hopefully we reduce the risk of violence, right? In our kids or our family members. Reduce or end abuse by early screening, teach families how to deal with stress and how to have fun, enjoy recreation. We had a whole section in our school, in our district, that offered like monthly parenting classes. You know, whether you were the parent of a preschooler or an elementary or middle school or a high schooler, right? How do we screen our families that are at risk? And then tertiary, when, you know, the abuse has already happened, when the signs of abuse are evident, right? What can we do for these families? Whether it's social service or counseling or mental health services, what can we offer them? So those are your 3 levels of prevention when it comes to violence. And then again, I would encourage you to review the Remember This. Okay. People in the United States are frustrated by an increasing level of violence. Okay, let's cover infectious disease real quick. Again, I don't know how much you guys have prepared for this week. So, you know, maybe you're keeping track of what I've highlighted here, but that's what we need to know. Okay, again, I've outlined our objectives. So you should be able to have a, you know, somewhat of a broad understanding of each of these objectives. Okay, we know that the emergence of infectious communicable diseases is growing at exponential rates, right? We know that migration, which is simply moving from place to place, right, can increase the spread of infectious diseases when people travel. And I may be domestically, internationally, just traveling state to state. Okay, so here are the most communicable diseases that we encounter. Okay, so first let's review Healthy People 2020. So these are related to infectious diseases, and they're talking about foodborne illness. All right, so there's lots of different communicable diseases. One part of that is foodborne. Okay, so let's see, increase the proportion of adults 19 years or older who get recommended vaccines. Okay, reduce infections caused by the Shignitoxin toxin produced by E. coli. Okay, that's a pretty broad objective. Increase the proportion of people who refrigerate food within 2 hours after cooking. That's reasonable. So this is part of the teaching we can do in the community. So we've already talked about agent host environment, right? We already know how everything's transmitted, right? You have to have an agent, right? We covered this, right? In epidemiology, right? We have to have an agent, which is the infectious agent, whether it's a virus, bacteria, chemical, right? It's your agent. Agent has to have a host to infect. That's us. All right. So how do we hold up? Is the host healthy? Is the host unhealthy? Are they immunocompromised? So the agent affects the host, and then whatever environment, internal, external factors brings to that formula. Okay, what if we're in a long-term care facility, we're elderly, and the agent is COVID? Probably more at risk, right? What if we are in high school and we're healthy and the agent is COVID? Probably going to be okay, right? So again, all those three, how a communicable infectious disease is transmitted depends on the agent, the host, and the environment, and the relationship they all have to each other. Make sense? And then it reviews all that. So a couple things we need to know. How are infectious diseases transmitted? Okay, they're transmitted horizontally or vertically. So I need for you guys to know what the definition of these are. Okay, so that could go on a card, but you need to know vertical transmission, parent to an offspring. Okay, through the placenta. Okay, horizontal, spread from one person to the other. You need to know what a common vehicle is and a vector. What's a vector? What's a vector spread? What are they spreading?
It's
Ticks.
yeah, it's what spreads the whatever it is. I'm
Yep.
so tired.
Oh, I'm sorry. Ticks, mosquitoes. Okay. Right. So they transmit by biting. Right. Please know, we need to know what a disease spectrum is. What does endemic mean? What does epidemic mean? And what does pandemic mean? We need to know the differences between those three. I think COVID is moving more into an endemic sphere right now, right? Which is, we're just going to have a constant presence, like the flu. The flu is endemic. It's always going to be there. Okay. Epidemic, it's a certain disease that is just, it's increased more than normal expectancy. Okay. And then a pandemic obviously is an epidemic that is worldwide. Okay. So have an understanding of what those three are. Okay. Know that list of reportable diseases, every state, there are national recommendations for reportable diseases, right? And then every state builds off that. So as a school nurse, I had a whole list, right? I had an infectious disease manual that I knew that if I got a call from a parent in a preschool that said chickenpox, reportable, it was preschool. Elementary school, middle school, chickenpox, no. Pertussis, reportable. Okay, so know that there are a list of reportable diseases. And if you're doing intake wherever you work and you're working with infectious or communicable diseases, there is a list of reportable diseases. Okay, what are some emerging infectious diseases? When we talk about emerging, we say over the last 10 years. Okay, first one, this is in your PowerPoint, Ebola. Okay. Second one, where are they? Ebola. So here are your 4 emerging infectious diseases. They consider HIV, Ebola, whoops, influenza. And where is the 4th one? West Nile. Those of you, so I just need you to know there are 4 common emerging over the last 10 years. Those are your 4. I think that might be one of the attestation questions. Okay. This is a great section on primary, secondary, and tertiary prevention of communicable and infectious diseases. So I would have a look at that section on page 202. Okay, what are some levels of prevention with infectious disease? Right, obviously primary, we want to prevent the occurrence of the disease, right? So maybe if at home they're changing wounds or changing dressings or changing dressings on stitches for kids, I don't know, educate about safe handling practices of bloodborne items, gloves, paper towels, whatever you're using, gauze, right? So that you prevent any kind of infectious disease from happening, right? Secondary, we want to prevent the spread of disease. All right, so let's say we have a foodborne outbreak. Okay, that's early identification. We have a foodborne outbreak. Well, the public health nurse, community nurse, she needs to go immediately investigate what the possible source of that is and stop that spread, right? Before people actually get sick from food poisoning. All right, an example of tertiary, reduce the complications and disabilities through treatment and rehab. All right, so you would immediately treat any foodborne infections. So they've been exposed, but then now they've gotten sick. Okay. Know these agents of bioterrorism. So some agents of bioterrorism are anthrax. I'm on page 203, smallpox. Those are the two. And then when we discuss vaccine preventable diseases, one of the most important things regarding education on vaccines when we work with parents is that parents need to know whether they agree with it or not, or choose not to get their kids vaccinated, totally up to them, and we should not be questioning it, is that we should at least try and educate them that we know it's a fact, vaccines are one of the most effective methods of preventing communicable diseases, right? We know that. Okay. And it goes through the list of childhood preventable diseases. Measles, rubella, pertussis. So we don't need to know that. We just need to know that when we're educating parents, whether they agree or not agree, they have to, it's the most preventable. Vaccines are. Okay. Then it goes through the foodborne illness. I just need you to know that what kinds of infectious diseases are out there. Okay. They may be foodborne, they may be waterborne. Okay. So just the types. Okay. I don't need you to know all the different kinds of foodborne illnesses. Okay. I don't need you to know that. Just knowing that food and water can create infectious diseases. Okay. Salmonella, E. coli. Then you have your vector-borne. Okay. So we had 4 kinds of infectious diseases above. Now it's just going through each one. Okay. Vector-borne, Lyme disease, Rocky Mountain spotted fever, malaria. Okay. Then you have your parasitic diseases. So just the types of infectious diseases. Okay. That's what I want you to know. All righty. Questions about that? Oops, I didn't mean to do that. And then I may have you do this last chapter. That was chapter 11, I believe. Yeah. I'm going to have you do this chapter on your own. Okay, communicable and infectious disease risks. Okay, and you can tell from this chapter outline what it's going to cover. All right, so please read your objectives and then go back here. Okay, this covers your STDs, it covers your different kinds of hepatitis, TB. Okay, I wouldn't worry about this top part, but certainly I would review your STDs, your hepatitis, your TB. And then obviously your nurses, the nursing role, which is primary, secondary, tertiary. Okay. Let me have you do that chapter on your own. Okay. I think what I'm going to do, since it's 12:47, we'll do the attestation. I'm going to send you with the recording the week 7 Kahoot. It's actually a really good one. Okay, so you'll at least have that to do. Okay, fair? Okay, everybody pull up their week 7 attestation, please. Did you guys learn a lot today? I know we covered a bunch of different topics, but helpful? And this is community nursing. Lots of different things. Okay, what's our first question in our attestation?
When discussing family violence and abuse, what are the signs of abuse?
Go ahead. Just everybody chime in. What are some signs of abuse? Did it say discussing family violence or just violence?
Family violence.
Okay, so what would be some signs of family violence?
Not allowing the patient to talk, talking over them, speaking for them, bruises, timid attitude by the patient.
Frightened. The other part of family violence can also be child abuse. You know, when you're seeing kids are presenting with abuse, that's family violence. Remember, family violence is child abuse, child neglect, could be intimate partner violence, right? What else? What's the second question?
What are the 4 emerging infectious diseases?
I told you. What are they?
West Nile, flu, Ebola, and what was the other one?
HIV?
Maybe.
Sydney's going to find us though. Sydney, stay on after. We need to pick another time.
Okay.
I don't know if you got my email. That should be right in your PowerPoint. There's a slide on that in your PowerPoint. I think we have it, but somebody double check your PowerPoint from chapter 11.
Ebola, HIV, yeah, flu, and West Nile.
And again, emerging, I know these all exist, but when they say emerging, they mean over the last 10 years. So. Okay, so I owe you guys the lecture recording along with week 7 Kahoots and then exam 3 study guide. And I'm going to reach out to Dr. Lundy to see when that might be available. Hopefully this week, because I like to have it out ahead of time. And then don't just open your HESI study guide. And as you start to go through it, hopefully you get a comfort level. Oh yeah, we covered this. Oh yeah, we covered this. We covered this. So that way it won't be so overwhelming. Okay.
We don't have an exam next week, right?
Correct. We have 8 chapters to cover next week. That's all.
Okay.
And then that's it. After
That's
next
all.
week.
8
That's
chapters next week. That's all.
8 chapters.
big deal.
Yeah, no big deal. Nope. And then that's it.
Whoever yelled no, I feel that. That's what I'm screaming internally.
Sorry, my mom's yelling at my dog.
Well, thanks for everybody who participated today. I appreciate it. I hope you guys have a good rest of the week. Please review chapter 12. Okay, take a look at your objectives, review chapter 12. All the other chapters we covered, Everywhere I highlighted should support understanding that concept. And some of you may be highlighting right along with me. I don't know. So yeah, that's great. But reach out if you need anything. And if anybody wants to review their exam, let me know. Whatever score you got, but I really want to hear from the people that got below a 78. Really do. So, all right. Well, have a good rest of the week. Reach out if you need anything and have a good rest of the day.
Thanks, bye.
Bye.
Thank you, bye.
You're welcome.